Speaker. I rise to speak about the use of do not attempt cardiopulmonary resuscitation notices during the pandemic. Last year, the health service was hit by the worst crisis in its history. The whole country was told to stay at home for one simple reason: to save the NHS. That meant not overwhelming the system with too much demand, too many people needing care. We faced the real nightmare scenario of the NHS not being able to treat people who were sick and dying. And the horrific idea emerged of doctors or local health managers or the NHS itself having to play God to decide who should live and who should die by deciding who should get treatment and who should not. Thankfully, the NHS was not overwhelmed. This is, of course, mostly due to the heroic work of frontline staff. It's also because every measure possible was put in place to reduce pressure on hospitals. That included people staying at home, it included building new hospitals at record speed, and it included getting people out of hospital as fast as possible, including to care homes. And this is where the occasion for the DNACPR notices came about, because care homes found themselves under enormous pressure too. Stories emerged last spring of blanket DNACPR policies, i.e. for people with certain characteristics being put in place in care settings. People with learning disabilities, people with certain complex needs, people with life-limiting illnesses. And this was done, the report said, without consultation with patients themselves or with families. Madam Deputy Speaker, all this was quite wrong and against all the guidance. Indeed, in April last year, the Care Quality Commission issued a joint statement with the British Medical Association, the Care Provider Alliance and the Royal College of GPs, reminding all providers that it is unacceptable for advanced care plans, with or without DNAR notices, to be applied to groups of people of any description. And I'm pleased they did this, and I'm particularly pleased that the Department for Health and Social Care, and I understand the Minister herself was responsible, asked the CQC to investigate these reports and to review how DNAR orders were used during the pandemic. I will come to their findings in a moment, but first I want to make clear that DNACPR orders are an appropriate part of our health and care system and can be a right and proper part of an individual's care plan. We need to distinguish between what might be called beneficial and futile uses of CPR. An obvious example of beneficial CPR is for young people with neurodegenerative conditions. Respiratory arrest is common for these patients, but with CPR they have an almost 100% survival rate. For them it is essential and necessary. But if a patient's other vital organs are shutting down, if they are dying, then CPR can do little. Happily give way.
And he and I share a very common cause, and I appreciate very much this coming forward. Does the Honourable Member not agree that for families such as myself, who last year lost a loved one, indeed my mother-in-law, we would like to believe that any and every measure was taken to save life, and the stories that we have heard and outlined and the Honourable Gentleman has referred to are simply heartbreaking. I share his concern very much. Thank you.
Thank the Honourable Member for his intervention, and I extend my condolences to him and his family for the loss he suffered, and I absolutely agree. And the value of this debate is perhaps to help communicate the expectation that all patients receive the care that they need right up until the moment of death. But CPR can greatly distress the patient and their family in the last moments. CPR involves a team rushing to the bedside, shoving aside any family members that are gathered around, and using what is basically a violent procedure, sometimes involving the breaking of ribs, to try to restart the heart. As one doctor interviewed about CPR described it, it can be chaotic, traumatic and brutal. That is not what any of us would wish when our death is imminent, even if it extends life for a few minutes or hours. So I have every sympathy with doctors and care home staff who want patients who are approaching death and their families to consider using DNACPR notices. But we have to be really careful about how they are used. Not just because of the obvious immorality of a blanket policy that effectively judges some people worth saving and some people who would be better off dead, without consideration for their circumstances or their wishes, but also because having a DNACPR notice influences the care you get more generally. And there is anecdotal evidence from care homes that patients who have requested that they are not resuscitated are not cared for as well as others. They might miss out on antibiotics for a chest infection, for example, or some other treatment for a reversible condition. The essence of the responsibility of doctors and care staff is that care should persist for all, whatever their condition or capacity. And this responsibility is well established in the law and the guidance. And I particularly value the principles in the 2005 Mental Capacity Act. which seeks fundamentally to honour the dignity of the individual, no matter their capacity or condition. And the MCA also sets out guidance on best interests, the test that should be used to determine medical treatment in the event of the individual being unable to decide for themselves. And crucially, a best interest consideration requires decision makers to take a view as if they were the patient. Not what they think is best, but what they think the patient would want. And this is vital. Madam Deputy Speaker, the CQC review concluded in February, and I'm greatly relieved with some of their findings and very concerned about others. I'm relieved that they did not find evidence of blanket DNACPR policies being applied as official practice by any health or care provider. They also found evidence of really good care being provided, including with the use of DNACPR orders on an individual case-by-case basis with proper consultation and consideration of the patient's best interests. But CQC report also causes me concern that de facto blanket policies may have been in operation largely because we simply cannot tell everything that's been going on. The report highlights some very serious failings. Of the 166 care records that the CQC reviewed, 103 should have included a best interest assessment. In only 33 of these cases is there evidence of an assessment being carried out. Talking to patients and their families, the CQC found that 30% of patients with a DNA CPR decision and 43% of families and carers did not feel the patient's best interests were fully considered. I'm glad to say that the opinion of people with learning disabilities and their families was more positive about best interest considerations in their DNA CPR decisions. Madam Deputy Speaker, I don't believe providers have been applying blanket policies. What I'm concerned about is the potential for such a thing. And I'm concerned that not all health and care providers are properly applying best interest considerations in the advanced care planning that they do with patients. So as the CQC says, we need to take a number of essential steps to prevent the possibility of abuse. And there are three main practical recommendations, and I hope the Minister can confirm her department is working to implement all of these. The first is that we need a more consistent national approach to the use of these notices. This emphatically does not mean a blanket policy for which patients should receive them. It means the opposite, a process to ensure that all patients are treated as individuals. And the CQC report particularly highlighted the RESPECT process, recommended summary plan for emergency care and treatment that helps everyone involved make informed decisions about an individual's future care and treatment. Second, we need to enable these conversations through proper investment in the training and support for staff who will have them. And third, crucially, we need proper oversight and assurance of the decisions that are made and proper record keeping. It really is scandalous that this wasn't in place already last year. We need comprehensive records of conversations and decisions. Integrated care systems should be responsible for monitoring the use of DNA CPR notices, and the CQC should be responsible for investigating anomalies, such as particularly high or low numbers of orders in particular places. Madam Deputy Speaker, I want to conclude with a final and more general observation about what we need that goes beyond these vital but ultimately technical remedies to the potential for abuse. What we need is a moral framework that honours the dignity of sick, disabled, elderly or dying people. This isn't something that the CQC or the DHSC or indeed this Parliament can simply draw up on a piece of paper. Indeed, I'm nervous about the idea of over-regulating end-of-life care, reducing it to a process, because at the end of that road lies the awful scenario we are trying to avoid, a blanket rule on who should live and who should die. We are never going to be able to write the rules of life and death, and every attempt to do so is ultimately dystopian. That is why the ultimate locus of decision-making should be in the conversations between doctors and patients and those who know and love them. We cannot regulate the good conversations, but we can certainly do our best to facilitate them, and that is what the CQC recommendations will help with. The only way to ensure good conversations is to ensure doctors and families have at heart the best interests of patients, and we in this place can encourage good conversations and the right decisions by stating as clearly as we can that human life is infinitely precious right until the end. Thank you, Madam Deputy Speaker.
Minister Nadine Dorries.
Thank you, Madam Deputy Speaker, and I thank my honourable friend for both securing this debate on this important issue of the use of do not attempt cardiopulmonary resuscitation orders, referred to obviously from now on as DNA CPR, and the decisions that were taken during the pandemic. We remain crystal clear that the blanket application of DNA CPR decisions is unacceptable, and the standards and quality of care should be maintained even in pressurised circumstances such as we've had over the past year with the recent pandemic. Reports of inappropriate or blanket application of DNACPR decisions across groups of people, particularly our most vulnerable, have been, he used the word I think himself, shocking, and failure to consult people and their families on decisions around CPR causes significant distress. He highlighted, he mentioned himself, the fact that the review undertaken by the CQC also saw examples of good practice that has taken place. Much work has taken place over the past year, and I would like to take this opportunity to update the House on the action the Department and the NHS and clinical leaders have taken to tackle this issue and to ensure that excellent patient-centred care is maintained. In April and May last year, clinical leaders issued a number of joint statements and letters to health and care providers and professional bodies, making clear that there has never been an instruction or a directive issued by the NHS to put in place blanket DNACPR orders. These communications also directly addressed and clarified best practice around the use of DNACPRs for people with learning disabilities and rightly challenged assumptions about clinical frailty regarding this particular group of people. Clear messages around the use of DNACPR decisions were also reinforced in our Adult Social Care Winter Plan in September of last year. We made it crystal clear that any advanced care decision, including DNACPR decisions, should be fully discussed with the individual and their family, and where possible and appropriate, and signed by the clinician responsible for their care. I myself have personally been through this process recently, and it is true, as my honourable friend mentioned, it is true that every situation, every end-of-life scenario is different. There are no two cases that are ever the same, and in my particular case, it was with someone with stage 4, very late stage 4 cancer. And the discussion was very, very simple and very easy and took a matter of moments. Involved family and clinician, but the person making that decision was very precise about what they wanted. And that scenario exists many times. But there are also people who may not have the full capacity or require further input and further discussions around those decisions that are being taken. And to ensure we could take early learnings and address directly concerns about inappropriate DNACPR decisions, because we're aware of the variation, I commissioned the Care Quality Commission, CQC, to review how DNACPR decisions were being made during the pandemic. CQC worked at pace to gather insight from across the health and care system. They took in views from experienced staff, from patients, their families and representatives to produce the in-depth thematic review on such an important yet complex, and it is complex, issue. I would like to take this opportunity to thank the CQC once again for their work, which was speedily and efficiently completed, as well as all those who participated in the review and shared their invaluable insight and experience. The review shone a light on what good conversations around end-of-life care should look like, illustrating examples of clinicians and care staff going above and beyond to deliver these conversations in a caring and compassionate way, despite the pressures posed by the pandemic. However, it also drew a worrying picture of the reasons why some of these conversations fell short of the high-quality, personalised care that people deserve. The report identified 3 key areas, as my honourable friend mentioned, where improvements must be made. Firstly, the CQC found a greater need for information, training and support for health and care professionals to hold DNACPR conversations. In particular, the report raised concerns that a range of equality groups, including older people, people with dementia, people with learning disabilities, were not being supported in the right way. Second, the report found that there lacked a consistent national approach to advanced care planning. Often the language used in holding DNACPR conversations was complex, with many different types of advanced care plans in use. Clearly, this lack of consistency runs the ongoing risk of affecting the quality of care that people receive. Finally, the report found that there were not always the right processes in place to ensure people experience personalised, compassionate care in relation to DNACPR decisions. Poor record keeping and inconsistency in how DNACPR decisions were reviewed, as well as a lack of system oversight, meant that it was not always possible to understand how effective these conversations actually were. Over the last year, our NHS and adult social care sectors have truly been the backbone of our nation, and staff have worked tirelessly to deliver outstanding care. Nevertheless, we must use these learnings as an opportunity to do better in areas where we can do more. Going forward, we must ensure that staff across health and social care have the tools required to appropriately and compassionately hold these appropriate conversations. We must also begin the journey towards normalising these conversations and giving people, their family, patients, their families and representatives the knowledge to truly be equal partners in their care. When staff, people and their families have concerns, we must put in place the best processes to ensure that people feel supported to speak up. This is why we strongly recommend the findings of the review and are committed, and I'm personally committed as the Minister responsible for this, to driving forward its recommendations. To that end, I will be heading up a ministerial oversight group that will bring together partners from across the health and social care system, as well as the voluntary and advocacy sector, to ultimately ensure that everyone experiences the compassionate care that they deserve. Sensitive and well-communicated DNACPRs can and should be a part of important patient care. And I should add that also, I'm not sure if my honourable my friend is aware, that the NHS on nhs.uk have now put up a public-facing message which explains the process of DNACPR and how those and the context in which they should take place, how those decisions should be taken, how those conversations should happen, so that actually everybody who wants to know what the process is and how it should happen can go onto the website and see that for themselves. And we've deliberately made that a public-facing message to be part of the general conversation around this. We're committed to taking continued action to ensure those decisions are managed and communicated well in all settings. Thank you, Madam Deputy Speaker.